So because the reproductive aging is a problem anywhere in the world, with the current trend of the world, the female partners, the females are also occupied, and the age that they would start to bear kids is increasing. So I mean, this is more like a problem for the doctors as well, doctors community as well, because the age of the age that they start to reproduce is increasing. So the fertility rate or the fecundity is reducing. As you can see, the highest fecundity is at between 20th 24 age of the age, and after 35 years of the age, there's a drastic drop of the fecundity, of the fertility. So not only for the Anuradhapura, but this is going to be a general problem in the future. All right, so before we try to tackle a problem, we have to identify the problem. So let's identify the problem. What is subfertility? So we have to go by the definitions. So the definitions are: subfertility is the inability to get conceived despite unprotected regular intercourse more than 12 months. So there are two types of it: the primary subfertility and the secondary subfertility. Primary subfertility being inability to have the first pregnancy or first kid, and secondary subfertility is where you have at least one pregnancy before, finding it difficult to get pregnant again. So the time duration is important, and making sure that they are engaging in unprotected vaginal intercourse without any contraception is important. And if everything is fulfilled, if still they are not getting pregnant, then we have to intervene. So if you think about the reasons for that, it could be due to the problems of the man, problem of the woman, or neither of them. It's unexplained. So the contributory percentage is equal, so it is nearly 33% each. Okay, so before talking about subfertility and its problems, we'll see we'll start with the simple sort of knowledge. So what is needed for a natural pregnancy? What is needed for a spontaneous pregnancy? You need a man, you need a female partner, and they should engage in vaginal intercourse. I mean, these terms, I mean, this information sounds pretty like obvious, but it's our considerations, because not in our culture, but in other countries, there are same-sex marriages where they find it like where they have to come for the fertility treatment to have kids. And vaginal intercourse, although though it sounds very obvious, there are couples who are like finding it difficult or coming to us saying that they can't bear kids, have kids, but when we dig in, they have not engaged in proper vaginal intercourse. When I was training in Castle Hospital, there was a young newly married couple coming to us with 2 years of primary subfertility. When we inquired into that, they have been engaged in intracreural sex for 2 years. So improper information. So vaginal intercourse is important. It's not a joke. During the corona season, the College of Obstetricians thought that the pregnancy rate should be reduced at least for the corona season. So we gave a proper information. It was not a mistake. All right. So the male partner should be producing functioning and motile sperms in his ejaculate. The female partner should be in the reproductive age. That means after the puberty until the menopause. Surprisingly, there's no such andropause for the man. He can shoot sperms until late age. So the female should be ovulating, and she should have functioning fallopian tubes with normal uterine cavity for the implantation, and vaginal intercourse. So every 2 to 3 days, including the fertile period. Now, don't get the message that this is the norm for everybody. So if somebody asks what is the normal frequency for a vaginal intercourse, don't advise that it should be only 2 to 3 days, once per every 2 to 3 days included. It's not like that. If somebody is having it daily, that is normal for them. If somebody is having it per week. Once per week, it's normal for them. They don't have to force themselves. But if a couple asks you, what is the normal frequency for us to have a baby? That should be at least once per 2 to 3 days, including your fertile period. So let's talk later what is fertile period is. And for a spontaneous pregnancy, for the insemination of the sperms, the man should have normal erectile functions during this vaginal intercourse, and there should not be premature ejaculation. Should not shoot up sperms before the main play. So let's refresh before we try to help our patients, it's mandatory to have at least the basic sort of, or refreshing the basic sort of memory about the pathway. So thereby we can work out, okay, where could be the problem? Because management of the subfertility is all about what is the problem and where is the problem. Okay, so thinking about where is the problem, it's very crucial to have at least a picturesque memory of this anatomy. I won't complicate it too much. Just take you through a basic knowledge that you should know. So, as we all know, so the vagina is like a cylindrical tube, a fibromuscular tube, into which we ejaculate the sperms, and it is also a sexual organ for the female, which gives the pleasure of the sexual activity, because sexual activity of the vaginal intercourse is not all about having kids. It's about having pleasure also. So these stretched receptors of the vagina will give you the pleasure of the vaginal intercourse. And also it is the first passage which will receive the sperms, and then comes the cervix. And sorry, before that, thinking about the problems where it can arise for the subfertility, can vagina be a place for a problem? Of course, yes. If she's having too much pain, if she's having difficulty in penetration, or if the man is having erectile dysfunction or premature ejaculations where he can't inseminate sperms into this vaginal tube, then the problem is there. You don't have to beat around the bush and do all the investigations and waste their money. A simple good history would make their life better. So, and when it comes to cervix, there is a cervical barrier. Sometimes there are studies for autoantibodies or anti-sperms as antibodies in the cervix in assessment of subfertility. So cervix there could be a barrier in the cervix. So the sperms traverse through the cervix and then enters the entity of this pear-shaped organ, the uterus, the uterine cavity, the endometrium. That has been the cradle for all the giants here who is sitting there, this pear-shaped organ. And then while it is happening, there should be a separate process going on, because if it is happening in the fertile period, the ovary of the female should produce an ovum or the egg, and it should be released into the fimbrial end of the fallopian tube, should be taken up by it, and at the ampullary region of the fallopian tube, it should meet the sperm. So this is the process in very simple terms. So the ovum can remain for 24 hours once it is released, viable, and the sperm can be viable for up to 72 hours. So if this time gap overlaps with each other, you get pregnant. Be careful. Okay. All right, so thinking about how the eggs are being released, there should be a central control also, which we call the HPO axis, or the hypothalamus pituitary ovarian axis. So nothing much complicated, just the basic knowledge, because it is needed to understand this. This is the ovary, which has primordial follicles within it from the beginning, and let's see what's happened. And this is the fimbrial end of the fallopian tube. So let's see what's happened after the puberty. The hypothalamus start to secrete GnRH in the pulsatile manner after the puberty. Pulsatile manner is important, which is sensed by the anterior pituitary to secrete LH and FSH, gonadotropin hormones. And this FSH hormone in the first 14 days of the menstruation, it start to proliferate select one or two primordial follicles and make them turn into Graafian follicles. They are multi-layered structures which has granulosa cells in the outer layer, and this granulosa cell layer will start to secrete estrogen, which is the hormone which can maintain your feminine activities, female nature. And this estrogen also have a negative feedback at the mid-cycle when it is in the higher concentration and stop FSH secretion. And by like the mid-cycle, there's a LH surge which promotes the release of the ovum into the fimbrial end in very simple terms. And this released ovum is being taken up by the fimbrial end of the fallopian tube and taken through the canal and goes to the ample region of the fallopian tube. And let's see then what happens afterwards. All right. So once the egg is being released, the same time the man has ejaculated. Now the sperms are traversing through the endometrial cavity, and one of the sperms, all of them meets the ovum. Not most of them, a few of them. And once the selected sperm enters the ovum, there's a merge of nucleic material and make this zygote. And there's a 2-cell stage, 4-cell stage, 8-cell stage, 16-cell stage, which happens until the 5th day after the ejaculation, and at the blastocyst stage, that is at 5th or 6th day of the after the ovulation, after the fertilization, the zygote get implanted in the uterine cavity and makes the bubble of life. So understanding the process in very simple terms or in a picturesque memory will make it easy for you to help your patients. All right, let's talk about how to assess a subfertile couple. Now at least we have a basic knowledge where the things can go wrong, and then we can find out where is the problem and what is the problem. All right, so when a couple comes to you saying that, okay, doctor, we are having trouble with having a kid, we are finding it difficult to get pregnant. So what we should advise is 80% of you will get pregnant if you try at least 1 year. So it is not a process which happens in 1 month or 2 months. You should try. I won't treat you unless there's a problem. If everything is okay, we should not be like wasting resources until 1 year. But it depends. If their problem is something like sexual dysfunction, even if they try for 10 years, it won't work. So it depends. If everything is otherwise all right, you should try for 1 year. And the woman should be at least under the age of 40 years, because elderly patients, okay, we will intervene before that. If you try another year, it will increase up to 90%. All right. So then how to assess that? It's again basics of the medicine. Take a good history, examine, and then only do the relevant investigations, which is very important information for you all, because you should not beat around the bush. The investigations which are there for the subfertility assessment, one thing is that they are very expensive. They're mostly hormonal profiles, invasive in treatment, and not available in the government sector for free of charge most of the time, especially these days. But still, there could be lucrative benefits for you if you do everything. But don't do that. It's not the right thing. If you have assessed your patient correctly, you can target or focus your investigations. And the other important thing is when there's a problem of fertility, both the couple should come. සමහරලාට නැන්දම්ම එනවා ලේලි වෙක්කගෙන. ප්‍රශ්නේ මෙයාගේ. So that's how they stigmatize the problem. අනිත් හැරෙන තපාලෙන් යවන්න ඕනේ මහත්යෙක් කෙනෙක්. It's not a problem of one part. Okay? You should not stigmatize by yourself. First thing is, how is your matings? How do you do it? The coital history. It's not a technical meeting of men and women. They should have good arousal. They should have the pleasure for a spontaneous pregnancy. It should be a pleasurable experience. If it is not there, then that is the problem. That may be the problem. If they don't feel like doing it, then help with it. Coital frequency, which includes the fertile period. So as we said, at least once per 2 to 3 days you should meet for you to get pregnant. And we should check whether they are having proper penetration, erectile dysfunction is whether it is there, premature ejaculations, any undue pain during sexual intercourse, which is again problematic. This part of the history is very sensitive. These are very sensitive information. Only a doctor will have the opportunity to hear from their patients because it's very confidential information. So you should develop a habit or develop a way of professionally how to take this information in professional conduct. Okay. නැත්තම් ඔවා කියන්නේ නැහැ. ඒක අහන professional way එකක් හදා ගන්න ඕනේ. If you are handling your subfertile patients, no one would reveal this information unless you show yourself professional. Okay, then one of the major concern is, are we meeting in the correct time? So 50% of the Anuradhapura couples are having this problem, not being able to meet in the fertile period. මහත්ය කොළඹ වැඩ කරන්නේ නැත්නම් මහත්ය ආමීකේ වැඩ කරන්නේ. දවස් 10 මාසෙට එන්නේ නැත්නම් ඉරිදා සෙන්සුරාදා විතරයි ඉන්නේ. Whole problem is there. So any GP, any primary care doctor, any family physician with the proper knowledge who are willing to help their patients, having the proper understanding can help them. No need for the referral for their VOGs. So how to find out the fertile period or the ovulation date? This is according to the duration or the time duration of their cycle. Their cycles could be 28-day cycles, 25-day cycles, or 35-day cycles. So we can't always expect to have 28 days cycles. So the first phase is the follicular phase and the second phase is the luteal phase. As you can see, whatever the total duration of the cycle is, the luteal phase is fixed. It's fixed to 14 days. So if, for example, if it is, and the ovulation date is the junction between these two phases. So if it is 28 days cycle, it is at the very middle of it. And if they are having 25 days cycles, it is on the 11th day. And if they are having 35 days cycles, it is on the 21st day. So accordingly, you have to find out their possible fertile period and advise them to engage in proper vaginal sexual intercourse covering that day. Okay. So this is simple knowledge which should help which would be a great help to your patients. Same thing, and the ovulation date. If somebody is having cycles which are going beyond 35 days, which we call oligomenoric cycles, very likely that they are not ovulating. So that is also an important thing to bear in your mind. So then they need ovulation support. So continuing of the history from the female partner. So you have to ask for the cycle, menstruation history, the interval of the cycle, as you said, and regularity of the cycles, because now for you to have 25 days cycles is normal for you, but you should have 24 days cycles in every month. If you have 25 days this month, 28 days next month, and 33 days next month, then you are having some problems with menstruation. But duration in general, 24 days, from 24 days to 35 days is normal for someone to have cycle interval between 24 days to 35 days is normal. That is normal range of menstruation, because that it's not like everybody should have 28 days. But if you are having your 32-day cycles, it should be 32 days. If it is jumping here and there, then ovulation. And other associated factors like pain during menstruation, which would suggest conditions like endometriosis, PID, which can affect your fertility. And presence of other medical problems such as thyroid dysfunctions, diabetes mellitus, previous TB, previous PIDs are affecting your fertility. Past surgical history like any pelvic surgeries and any tubal surgeries can affect your fertility. And the family history of the same problem. And history from the male partner, presence of other medical problems. Diabetes can make you impotent, and thyroid problems can make you to have abnormal sperm generation. And past surgeries, testicular surgeries, trauma, where there can be a breach to the blood testis barrier, and childhood moms resulting smoking and alcohol. You should advise your patients smoking and alcohol can reduce the quality of the sperms. Now the research says that having standard amount of drinks, this is the good news, standard amount of drinks, 2 to 3 units per week, which is not very good, is not affecting your level, sperm quality. It's not affecting, but beyond that, it can affect. If you are having problems with fertility, then you have to really cut down on your habits. All right. So let's touch upon the commonest problems where we encounter this. So ovulation problems. Commonest problem is ovulation. And again, out of that, the commonest reason is polycystic ovarian syndrome. It is the commonest endocrine problem of the female. And thyroid dysfunctions can affect that, and diabetes mellitus can affect that. So during an examination, look at the female partner and see whether she is looking polycystic. Having acne, generally like high BMI more than 30, having acne, excessive facial hair, what else? Irregular menstrual cycle in the history. So having high androgenic states, features of high androgenic state is suggestive of polycystic ovarian syndrome. Okay, and whether it is a tubal problem. So in the history, in your assessment, if these factors are present, then the focus should be that. Okay, and you are ovulating, your tubes are okay, but the zygote can't, or the blastocyst can't implant into the uterine cavity because something is on your way. Submucosal fibroids, septated uterus can do that. So then that should be a focus for your assessment. During your ultrasound scan, in the basic assessment, you should look at the uterine cavity with the ultrasound scan to exclude the presence of submucosal fibroids which are obstructing the cavity and any evidence of septated uteruses. So with this sort of general clinical assessment, having an idea, thinking where could be the problem, then we go for our investigations. So as I said, we should not beat around the bush and target everything because they are expensive. So you should focus. Assessing the man is easy because if he's having good sperms and having no erectile dysfunction, the problem is like minimal. So WHO has given a reference value for human semen, what are the normals? I'm not going to read out the normal reference range, but it's very easily you can refer it in the internet. It's available in the internet, and any sort of laboratory with their reports will give the reference range also, so you can check whether it is normal. So female partner. So as I said, we should assess them both together. So in your first encounter, you should perform a transvaginal ultrasound scan. So there we assess the ovary for the presence of PCOS and other conditions like endometriosis and uterine cavity abnormalities. See whether there is inception and other congenital abnormalities. Presence of uterine fibroids. Presence of pelvic endometriosis. And do a TSH if it is clinically indicated. And also not to miss a presence of pre-diabetes or diabetes. Arrange fasting blood sugar as well as a preliminary investigation. So then how to assess the ovulation? After the first transvaginal ultrasound scan, you need to know whether this female is producing an egg when they meet in the fertile period. In your history, if they are having regular menstruation, that means the cycle interval is regular, then the 90% of the time they are ovulating. But still, the guidance recommends us to do a mid-luteal progesterone as a test of ovulation for all women undergoing fertility assessment. Mid-luteal progesterone is, in simple terms, now if they have ovulated in the middle of their cycle, if the ovum is released, then that Graafian follicle becomes what? Corpus luteum. Or if only they ovulate, a corpus luteum will produce. Otherwise, the follicle will remain in the outside of the uterus, the rim of the uterus, as antral follicle. It is not producing progesterone. But if they ovulate, it will become corpus luteum, and in the mid phase of the luteal phase, that is in the second half, it has the highest level of progesterone, which is the mid-cycle progesterone. So that is why you need to know the ovulation date, and accordingly you can calculate when they can have the mid-luteal progesterone. Because 21st date mid-luteal progesterone is for females who are having 28 days cycle regularity. But if their cycles are in 35 days, then their mid-luteal phase is going to 28 days. Okay, so that is why you need to have a proper knowledge, a basic knowledge about these things. And if they are having no regularity of the cycles, then you can't assess their ovulation with mid-luteal progesterone. Then you have to use the gonadotropins to see whether they are high. If the gonadotropins are high, FSH and LH are high, that means there's no negative feedback from the downstairs. So they are not producing ovules. Estrogen is not there. Progesterone is not there because of estrogen is not there because the Graafian follicles are not producing estrogen. Progesterone is not there because the corpus luteum is not producing. So there's less negative feedback for the FSH and LH, and they are in a high level. And especially for elderly women who are waiting for their IVFs, there are tests for ovarian reserves. There are antral follicle count, anti-Mullerian hormone level, and again FSH. So these are third line tests when it comes to fertility assessments. I have not come up with the reference range, but total antral follicle counts less than 4 is kind of a less ovarian reserve, and anti-Mullerian hormone level less than 5 international units, and higher FSH levels are like indicators of low ovarian reserve. Okay, so you first assess whether the ovary is producing eggs, and then you go to the tube. So assessment of ovulation, assessment of the tube, and assessment of the male partner. These three preliminary investigations should be carried out for all the patients who are undergoing fertility assessment. So what are the methods of assessment of the tubes? The simple and most commonly used method and recommended method is HSG, which is hysterosalpingogram, and then we have laparoscopic dye test. So HSG is it doesn't need any anesthesia. No much sort of clinical expert is needed. You just inject, while the patient is awake with a pain relief, you inject radiopaque dye into the uterine cavity. And at the same time, you take x-rays and see whether there's a spillage of dye into the pelvic cavity. Radiologist will guide us with this. And the good thing about this is it doesn't need anesthesia. And you can see the internal structure of the cavity. That is not the uterus, that is the inside cavity of the uterus, that is V-shaped structure, triangular structure. And that hair-like lines are the inside cavity of the fallopian tubes. This picture is not given by your laparoscopic and dye test because we have seen the organs from outside. Here we can exactly say, okay, where is the problem, where it is getting stopped, or whether there's any cavity abnormality. Whereas, on the other hand, laparoscopic dye test is far more superior, but still needs anesthesia. What happens is, under the anesthesia, one operator is injecting the dye through the cervix while the surgeon is looking at the organs macroscopically through the camera. So you can see the uterus and you can see the tubes, whether they are anatomically normal, and you can see the spillage of the dye. And the good thing about this could be therapeutic as well, not only the diagnostic. If there's any additions to the tube, you can correct it then and there. If there's any problems of the ovaries, like polycystic ovaries, you can drill the ovaries. You can treat the endometriosis, so it has therapeutic benefit. How to manage? It depends on where is the problem and what is the problem. So it is not always by the gynecologist or the fertility specialist. We need help from the other departments. When it comes to IVF and other advanced reproductive technologies, we need the embryologist. We need the laparoscopic surgeon if she's having endometriosis, and endocrinologist most of the time comes into play. We need neurologists sometimes if it is something to do with the hypothalamus, and psychiatrists and psychotherapists mostly for the sexual dysfunctions and the anxiety and depressions which is associated with subfertility. If I try to summarize how to manage in very simple terms, if it is sexual dysfunction, don't do any other investigations. Refer them to a person who can actually help them. Take your time, do the maximum that you can do at your level. Explain how to do the proper sex. Tell them that it's not like, it shouldn't be a forceful thing, it should be a spontaneous thing. Undue fear, you can identify the anxiety disorders associated with this. Gradual sensitization methods like cognitive behavioral therapies, like gradual sensitization, you can do it by yourself, help your patients by good advice. But if it is beyond your expertise, always refer them to a specialist. If it is ovulation problem, go with the ovulation induction. If it is tubal defect, if it is correctable tubal defect, laparoscopic adhesive lysis or tubal reconstruction surgeries would do that. But unfortunately, most of the tubal defects, if your tubes are blocked, then you need IVF. Male factor, most of the time, male factor infertility is also difficult to treat. But still, the couple can get pregnant with donor sperms insemination. And the most difficult entity of the subfertility is unexplained subfertility, where there is nothing wrong about both of them. And most of the time, they are not getting pregnant. If they are not getting pregnant, we need IVF. Okay, now I'm not again going in teaching you how to do the treatments. Anuradhapura problems, which is the commonest cause after the sexual dysfunction. So if you find that your patient is not ovulating, then you can use your ovulation induction method. So you assess the menstruation. If it is irregular and mid-luteal progesterone is less than the reference range, less than 13, then you think, okay, and she looks polycystic, okay, then you think this is an ovulation. So how can you treat them? After either menstruation, spontaneous menstruation or induced menstruation, you can use either clomiphene citrate or letrozole as oral agents from day 2 to day 6 of the cycle, that is during the follicular phase. So how does clomiphene citrate works? It acts by central pathway to increase the amount of FSH. Letrozole will inhibit the estrogen production in the peripheral fat tissues, thereby increase the FSH secretion, because when the estrogen is less, FSH goes high. Because the idea is to increase the normal amount of FSH, follicular stimulating hormone, thereby increase the follicular generation. And if the oral agents are not working, give FSH injections. I'll touch very basic things about assisted reproductive techniques, very basics. In Anuradhapura, we have the facilities to do IUIs, in utero insemination. Still, unfortunately, we are not having that facility in any of the government hospitals, which is sad. And we have to depend on the quality of the work from the androgen labs and the medical laboratory technicians, and we don't have a control about how they do it and what standards they maintain, what reagents they use to make the sperms. It's kind of problem. There's no quality control of this process in our country. So the success rate is not very satisfactory even for the IUIs. What do you do there? So in very simple terms, treatment workup, that you talk to the patient and see whether there are any contraindications for pregnancy, check the TSH, check the fasting blood sugar, and do the counseling. And then, as I said, you can do the ovarian stimulation to induce ovum generation in the first 14 days by giving your letrozole or clomiphene citrate. And then by the ultrasound scan, you monitor the response. You do the follicular tracking and see whether the follicles are being generated. And near to the ovulation date, that means 36 hours prior to the ovulation date, you give LH. You give serum beta HCG, which is a substitute of luteinizing hormone, LH. It's equal to the molecular structure. Thereby, you trigger the ovulation. And then, once they come on the ovulated date, possible ovulatory date, you get the man's semen and concentrate it and deposit in the endometrial cavity. In simple terms, it's that. Okay, so we pick the date that she released the ovum after preparing the ovary and concentrate the sperms. There are two methods, swim up method and density gradient method, and take the supernant of the sperm and with the plastic catheter you insert into the inside cavity, avoiding the barriers from the cervix, avoiding the barriers from the vagina. You directly inseminate the sperms into the uterine cavity on the correct date. So you have to advise your patients, at least you have to try 6 cycles of it if it is not getting pregnant by your person. So, and something very simple about IVF. So the basics are that, again, like in the IUI, you do the ovarian stimulation with the hormones. The hormone the injected hormone, the FSH and the estrogen will induce follicular generation, and by the ultrasound scan, with the transvaginal ultrasound scan, you go into the follicles and suck out the ovums. So you retrieve the eggs outside. You retrieve several eggs per time. So this is how it shows in the ultrasound scan. Needle goes in, take out. Needle goes in, take out. And then the second phase is egg pickup, yes. Then third, you prepare the sperms, same as in IUI, concentrate it, and in a Petra dish, we let them to fertilize and see the embryo development. And you pick up day 4 to day 5 embryos and implant them into the endometrial cavity, which is called embryo transfer, which is costly. The minimal cost in Sri Lanka is still around like 2 million, which is very unfortunate. Most of the couple who are not having good results with IVF, IUI, the next step is for us to refer them to IVF. But when we inform about the anticipated cost, they get devastated. There's no way that they can afford 2 million. In developed countries like NHS UK, they do it free of charge up to 2 IVF cycles if the criteria is fulfilled. So I don't know where we are standing, or maybe for the next 100 years, whether we could afford that. All right. So for you to do this, the man should produce adequate amount of sperms, and it should be it is generated in Petri dish. But suppose if the man is having very little amount of sperms, but still you can pick one sperm from the testis and take it out, then you have this ICSI, which is called intercytoplasmic sperm injection. Intercytoplasmic sperm injection, where under the microscope you take the ovum and take that one lucky single sperm and inject into that and let them grow. All right. So that is the management of the subfertility in very basic terms. If you have any questions when you're managing your patients, which you encountered, we can have a discussion. And as I said, the bubble of life it comes with so much of hope. It comes with so much of expectations. People get so much they come to us, the couples come to us with so much of confidence, keeping so much of confidence about their doctors, thinking that we will do the right thing. But sometimes it's very arbitrary, because always the bubble of life is not very fascinating. Some couples get devastated getting to know that they are getting pregnant. So especially these days with this financial crisis. So it's not our job to judge on their decisions, not go by what we think what is right. But still, if there's a problem, we should have proper knowledge and empathy towards our patients to do the right thing. If you stick to that, the results will be fun. Okay. All right. Thank you.